So long.
Oh, don't be sorry. We're just glad that we finally got you on.
Okay, how's South Dakota? Cold?
It is cold, but it's not snowing today, so this is a good thing.
Show us on the
Okay.
screen. Wait, did I do it?
Okay. Okay, so tell me about what we're doing here. How's it work?
How does it work?
You can pull up the stuff you want to show us and put it on that screen over there.
Okay.
We're recording everything starting now.
But you can edit it? Okay.
Yeah.
So,
Yeah, we'll be able to edit it,
okay.
and I can see your screen.
Okay.
Yeah, and Matt, if you want to, while you're walking through it, if there's any places that you know that you and Dr. Geppert know that you want to maybe take out, so if you'll write down like a starting time, and then if you're like, oh, I think we want to cut this, or maybe we want to edit that, if you'll write those times down, then when we go back to edit, then it'll kind of give an approximate place to look for those things.
Sounds good.
All right. I would do it, but I won't be able to stay on for the whole call.
So start?
Whenever you're ready, we'll give you a 3, 2, 1, and then I'll turn my camera off. Okay, and 3, 2, 1.
Okay, welcome. My name is Cindy Geppert. I'm a psychiatrist and palliative care physician and ethicist at the New Mexico VA healthcare system, and formerly had a life in chaplaincy before medical school. So I'm very grateful to Chaplain Mellon, Chaplain Cassidy for asking me to participate in their advanced chaplain training. So what I'm going to do today is I'm going to talk about ethics and how ethics and chaplain service can interact both positively and in a challenging way. The first thing I'm going to do is I'm going to take you through all the resources and programs of the VA's National Center for Ethics in Healthcare, and that's on your screen. And all you have to do is put in the VA's National Center for Ethics in Healthcare to your VA browser. There's an intranet and an internet version. We're going to look at the intranet, what's available for staff. And so you can see we're there, and there's a number of different options. So the National Center for Ethics in Healthcare, it supports the field, just like the National Chaplain Service. In their work, there are ethics consultants and integrated ethics program officers in every single facility. Many of you may have filled those roles or know other chaplains who do, or be interested in contacting the integrated ethics program and participating. It's great to have chaplains on the ethics consultation service, and there are a number who are actually the ethics consultation coordinators and integrated ethics program officers in the VA, in addition to their other chaplain duties. So we have About Us, which talks about what we do. So we just recently, the National Center for Ethics in Healthcare was awarded the American Society of Bioethics and Humanities, ASBH, which is our professional organization for ethics, highest award, which is the Cornerstone Award. And so we're for making a lasting contribution to ethics and humanities in healthcare, and we're very proud of that. So what we do for our staff are we try to clarify and promote ethical healthcare practices across the board, from individual decisions and actions to systems to processes to environment and culture. We'll talk a little bit more about that when we get to integrated ethics. We provide analysis, information, education, advice, and support, and work collaboratively with the field. And we are available to veterans, their loved ones, and staff across the VA. So anybody that's in the VA, we're there for. And as you can see, there's our Cornerstone Award. So in every VA, there's a consultation service. Those consultation services work with our National Ethics Consultation Service, and anyone can reach out to us for a consult. We'll usually try to loop in the local service if appropriate, and you see there vhaethics.va.gov, and if you write that, then we'll get it at the National Ethics Center, and somebody will triage it, and they will respond to you and either connect you to local resources or work with you and those resources. So what's an ethics consultation? Well, it's sort of like a chaplain consultation, but it's different. So it rather than spiritual issues, it provides consultation on healthcare ethics, and to anybody who's involved in that. And so we assist with problems that can't be resolved locally, practical advice, and work with requesters to clarify VA ethics standards and policy. I'll be taking you through the policies to discuss your concerns and refer you to resources. So when do you know if you need an ethics consult? Well, when there's a lack of clarity about an ethics policy or concept, or uncertainty surrounding an ethics-related situation. We like to shorthand say where there's a conflict of values or uncertainty about values, then that's probably in the bailiwick of ethics, and either locally or nationally. So we provide ethics analysis, we review documents, we cover patient care, healthcare management, and research. We talked about clarifying policy, and we just answer questions and provide resources. So there's a local consultation service, and there's a national consultation service, and it's a good thing to know about both of those. Some resources for veterans and families that I want you to know about because you're working so closely with them, especially on difficult decisions and end of life and tough medical treatments. They have to make choices. So there's a number of resources. There are VA advanced directives. I would really recommend these two. Your rights regarding advanced directives and what you should know about them are great handouts, both for you to educate yourself and also for those that you're ministering to. Setting Healthcare Goals is a podcast that talks about how you work with your loved ones to figure out what you want about your health care. We also have mental health worksheets for advanced directives. And then we also have some nice podcasts that are with veterans usually, or others from the field and our experts that talk about what informed consent is, and other things about opiates, etc. So those are some things to check out, and I'm going to show you today, talk you through way more than you can access, and so this is just kind of the 1,000-foot level, and if I'm really nice and pray hard, to maybe Matt and Kristen will have me come back for to dig into some of your questions and cases and concerns. So integrated ethics. Integrated ethics is the innovative structure, it's award-winning, that VA developed in 2007 and implemented in all the facilities. And it has 3 parts, and we'll go through those. And it's a comprehensive approach to ethics. There used to be, and some of you may remember in those days, if you're gray-haired like me, Matt's 23, but if you remember, we used to have ethics committees, and some of you may have served on ethics committees either in the VA or other facilities. The VA found those to be problematic because they often had way too many people with way too little training, and it would just weren't providing good guidance, and also often overwhelmed the patient and the family members that were trying to get help. So they switched to a more professional model of ethics consultation services and the integrated ethics program, where you do have to have some training and have a more cohesive group that's responding to requests. And so the structure is like this. There's an IE council. Many of you may sit on that IE council, which is chaired by the senior leader of the facility. That is the governing organization for integrated ethics. And then there's the 3 parts. Ethics consultation, we've already talked about. Preventive ethics looks at ethics issues at a systems level, and this is one of the more unique aspects of VA ethics, addressing quality gaps. So if, every time someone says that they don't want resuscitation, somebody fights them about it and doesn't follow through on that, that would be a systems level issue that you'd want to look at. So that's preventive ethics. Ethical leadership is really, at the very top, the director, the chief of staff setting an ethical tone for an ethical culture, rewarding ethical behavior, discouraging less than ethical behavior, and really leading the way to do the right thing. So at every facility, there's an ethics consultation service, a preventive ethics team, an integrated ethics program manager, and an ethics leader. And all of those have, under each of these, have lots of different information and training manuals and support and all those things about the integrated ethics program. So that's just an overview, and there's lots more. I want to turn now to something really important for chaplains to know about, which is another incredibly forward-thinking VA ethics program, 10 years in the making, the Life-Sustaining Treatment Decisions Initiative, LSTDI. Chaplain Cassidy was on our work committee here that implemented it and was invaluable. LSTDI varies. Some places it's really up and running everywhere and really permeated. Other places, facilities, the uptake has not been quite as strong. It's a pretty complex program, and so there are bumps on the road as we get it in place, but there's really nothing else like this in any other healthcare system. So what it is a national quality improvement project, and it aims to provide personalized, proactive, patient-driven care for veterans with serious or life-limiting illness. And it does this through a policy, but also a program to elicit and document and honor their values and their goals and preferences. It tries to standardize those, to discuss and document goals of care. And there is a note that chaplains can use, and we very much invite them to participate. Our palliative care team has a wonderful chaplain. Many life-sustaining treatment decisions committees have chaplains. And it provides tools, resources, education to support clinicians in making this really huge culture change. So the policy is fairly long, but it's excellent. And then these are just some different tools for the different stakeholders. So for patients and families, healthcare facilities, clinical staff, patients and families, it provides a number of educational documents that I think are really helpful. I want to especially draw your attention to these individual booklets. The ones on feeding tubes, dialysis, mechanical ventilation, and CPR are awesome. And they're good things for chaplains to know about, both to educate yourself, but then to help families, because they provide the basic medical information, but in a values-based context, so that you can have the facts and also help to inform the choices of patients. And those are available on our website, and then we have some podcasts about those procedures as well. So I think those you will find helpful. The rest of this is rather specialized for people who are implementing or carrying out the LSTDI, but I encourage you to find out who your LSTDI coordinator is and figure out what's going on and how you can help, and how it dovetails with what you do in chaplaincy. Next is education, and there is a ton here. I am in the process. I owe Kristen, Chaplain Mellon, I haven't gotten to it, but I'm going to revise the materials that were provided to you for ethics. Some I think aren't quite as helpful as some other things, and some are really right on. But let me walk you through what the VA has. If there's something you want to know more about, feel free to contact me directly. I have a number of advanced degrees in religion and theology, and so I love talking to chaplains about theological ethics or moral distress. So integrated ethics training is for that group. Assisting patients with advanced directives is for social workers who tend to have those groups. Goals of care conversations is how to learn to talk to families and patients about end of life. There's a number of basic online learning TMS modules that if you just want to kind of get the lay of the land in VA ethics, I encourage you to take. They're pretty straightforward, but you can get a good basic command. And then there are, as we talked about, a number of multimedia and podcasts. And so Sounds, Ethics, and Healthcare is a little series that we did, and we're actually, I think, going to do some more coming up here. So you might have, a question that a veteran came to you with, and you're just not sure if they're telling you is really what policy is, or is this just an individual clinician and you're trying to help them with it. So here's some great ways to get that information. Prescribing home oxygen to patients with smoke. This is who smoke. This is a big ethics issue. Patients smoke. They put themselves at risk. They put others at risk. You've probably had pastoral visits to patients who burn themselves. That's a problem. Identifying the surrogate. How do you get your close friend when you don't have family? We have lots and lots of disenfranchised folks that are in our system who don't have actual family, but they may have someone else who could help. I'm sure you've heard about opiate therapy, informed consent, urine drug testing. Why do we do those? Is that a violation of privacy? How are we respecting patients doing that? What's the difference between a life-sustaining treatment order, which is something a doctor puts in the chart, and an advance directive, which is something a patient completes? And how do those work together? And then there's some ethical leadership podcasts as well. So wanted to tell you about that. And then this is a nice series as well. You can just sort of listen to these on the treadmill, whatever. Why should I complete an advance directive is a really good one to encourage people, and we really ask for your help in getting those done. Choosing a healthcare agent, I think I might have done this one, so it must be good. No, I'm just kidding. So I've been chosen as a healthcare agent. Now what? And both of those are very good to help people. Often, suddenly a loved one is really sick. A family member has to make decisions. There's pressure from other family members. You're trying to support them. Some good guidance here. Thinking about healthcare goals, again, some nice things on CPR and mechanical ventilation that can assist you when you're trying to counsel veterans and their families in these just sad situations. Let's see, where am I? Okay, I'm going to go back there, and then I'm going to go here again. Okay, so back to education, and then we got through that, and now we're going to go to the place I want to spend the majority of my time is to walk you through VA policy. We could do an entire session on each of these. We're not, don't worry, don't be scared, but we are going to talk to you about the big ones so you can know where they are and if you want to study further. So why do we have policy? And we have lots of tools to support it. As you'll see, we have policy to respond to changes in law, regulation, clinical practice, public health, and when we have to establish national VA standards to respond to system-wide problems or vulnerabilities, to address gaps, to ensure coordinated care, and to support programs. So an important principle of all VA ethics is that we are not governed, except in some rare exceptions, mostly mental health care, by state law. So whatever the state law says, that's great if you're in the community, but for the VA, we're under federal law. And so the Supremacy Clause says we defer to federal law. So our policies, each of them, is grounded in federal regulation. It's not just a policy like you might have at a community or academic healthcare center. They really are expressions of federal regulations. And so they carry a different weight and force, and they also are what we need to follow if we want support from our leadership and legal and everybody else, because if we follow policy, then we have the backing of that, rather if we just kind of go out on our own. We're not adhering to the rules that have been put in place for us to practice ethically. So the first policy is advanced care planning and management of advanced directives. We've talked a lot about advanced directives, and it's good to realize that VA does honor state directives. What are the conditions for somebody to be able to complete an advanced directive? Who can serve as a surrogate? All those kinds of questions that you probably get. We talked about rights. We talked about mental health. What does it mean to change your advanced directive? The FAQs are very good when you're got a question and you just don't quite know how to answer it. But an entire policy on advanced directives is here. The next policy I've clicked on, disclosure of adverse events, is among the things I'm proudest of in the VA. And we led the way through our Lexington facility. Often in the old days, when something went wrong, nobody told the patient, nobody told the family. The lawyer swooped in, and everybody sort of dived for cover. Now it's not the case. We have an entire directive that tells us how to approach adverse events. Not all mistakes are adverse events, and not all adverse events are mistakes. But when something does go not as well as we wish, then we actually let families know, we formally apologize, and we document that what happened. We offer to make reparation. We try to fix it. I've had the great privilege of doing institutional disclosures, which are when the adverse event is more serious, done at the level of the chief of staff for 15 years, and I can't say all of them were, people were happy, but on the majority, the first thing the vet asks is, how are you going to keep this from happening to another veteran? They're often very moved that we respect them enough to bring them in and tell them, the difficult truth that we didn't do things as well as we would have liked. Clinical disclosures happen all the time. That's less serious events, and any staff member can do that. There are large-scale disclosures. So the VA, unlike any other healthcare system, say someone doesn't clean a scope or uses a medication that's contaminated, something that affects hundreds or thousands of veterans. There's actually an entire committee and process for working with notifying and caring for those veterans. But VA really, really focuses on transparency, consistency, and fairness when adverse events occurs. So something to be proud of. I'm going to skip financial relations between VHA healthcare and industry, because actually that's been moved over to another office and not something I think chaplains would have a lot to do. IMED consent is the way we all get consent, and I'm going to go down here to informed consent. Probably this is the central policy in all of VA that's used the most often. And it says who can get informed consent, how informed consent should go. It is the kind of rules for the value of shared decision making, respect for persons and veterans' autonomy. You probably heard those words. It lays out what requires signature consent, what's oral consent, who can give consent, as I said, what should be the elements of an effective informed consent conversation, and then most importantly it says, what do you do if a patient has no capacity, which we find increasingly with our aging veteran population, and even more, what do you do when a patient has no capacity and has no surrogate decision maker? So unlike many systems where you have to go to court, it can take a long time, the VA has the option of its own internal algorithm whereby either the attending or the chief of service or a committee or the chief of staff can make a decision for a veteran either who doesn't have capacity or a surrogate, a medical decision, either based on what's called substituted judgment, in other words, the patient's values and wishes and preferences if known, and if not, in their best interest. And so that's another novel aspect of VA ethics that I think is very much more patient-centered than going to court or having a strange guardian who doesn't know anything about you or what you would want. And so a good policy to really know about. Or if you ever wonder, is that doctor do that right? I mean, then you can look it up there and see, and then politely tell them, no, you didn't, because I had an ethics class. Just kidding. So informed consent for long-term opiate therapy for pain. I don't think that's a big one for you. I'm sure you hear veterans who are upset about their opiates being tapered, but this is sort of the guidelines for how you prescribe opiate therapy. We get informed consent for it because of its high risks. Integrated ethics is what governs our integrated ethics program, that policy. The VA life-sustaining treatment handbook, I already talked about life-sustaining treatment decisions. That's available here. So it's good to know that. The National Center for Ethics we talked about, and then state authorized portable orders are if a veteran's in the hospital and the veteran talks to his team and his family and decides, he's pretty sick. He really was DNR in the hospital, and he would like to continue that status when he goes out to a nursing home or even his own home. Then every state has a form that can be filled out, and it's usually on yellow or pink paper, and then pinned to, say, your refrigerator. So if you have a cardiac arrest and EMS comes and they see that, then they will honor your wishes to be DNR. So another important thing for chaplains to know about when they're counseling patients or, being with families, you may hear, oh, I wish the EMS wouldn't come, and, the EMTs start. EMS is the people who do all our house cleaning. EMTs, the emergency medical technicians, wouldn't, resuscitate him. And this is a way that you can carry your wishes forward even into the community where a VA order like a life-sustaining treatment decision wouldn't be honored. Okay, and then just some other things. So ethical issues in Ebola we've looked at, pandemics, Hep C treatment, post-traumatic stress, and this is just to give you an idea of the wide number of ethics issues that come up. Every time I think I've seen it all, I get a different call. I've now clicked on the National Ethics Committee's reports. We used to have a wonderful ethics committee at a national level that produced some just awesome publications, and just look at a few of them with you. Long-term oxygen, as we talked about in smoking, mental health directives, impaired driving in older adults. That's one you probably have families coming with. It's important to know you can't really pick up the phone and call MVD and report an elder who's at risk driving with dementia, even except in very few states. I would like to, this is probably the best of all the reports for those of you who are interested in it. What are the roles of surrogates? What are their authority morally? We place the locus of control really for medical decisions in families, and usually that's good, sometimes not so. But what are the ethics behind that? An excellent palliative sedation, gifts, ethical boundaries. I think boundaries is important, of course, in chaplaincy. Would also like to recommend 10 myths about decision-making capacity. I give this to everybody. I think it's one of the best things the VA ever wrote. Talks about how patients with mental illness and dementia actually can make decisions, and how a person can make one decision but not another, and it's not monolithic, it's not absolute, there's lots of gray in there, and just some other interesting things. Okay, so I talked about policy. I've showed you some of our, this is not as relevant for you all, publications. Did want to show you this. So we talked about the National Ethics Committee reports. There's Ethics RXs that look at problems with policy that came up that we thought were worth writing about. And then here's the National Ethics teleconferences calls that we used to have. Don't have them anymore, but I wanted to point out to chaplains, and it'd be actually really good to do an entire session on this, but the ethics of right of conscience in healthcare settings, both for all VA employees, but for practitioners, I encourage you to look at that. Obviously, questions and dilemmas at the beginning and end of life often raise concerns about what's called right of conscience or conscience clause or conscientious objection. And this is a good overview of where the VA stands. And also things like caring for LGBT, caring for sex offenders, those sorts of concerns that I know have come to you as chaplains. The basis of informed consent is a very good one. And then, as you see, some of these are less relevant than others. Resource allocation is always something that often comes up. I would like to also recommend to you moral distress. The VA National Ethics Center had a moral distress initiative for a while. I feel like this is a place where ethics and pastoral care really intersect. And you all deal with a lot of spiritual distress, moral distress, moral wounding. These are all areas that you probably know better than we do, and we can all collaborate on. So encourage you to look into that one. And unsafe discharges is also interesting. I'm sure you've seen staff struggle with people they don't think can care for themselves who are going to leave nonetheless, or people who want to leave and can't because they can't care themselves. And I think chaplains get in the middle of a lot of those for trying to mediate. Older drivers is another one that comes up, and there are just a number of concerns. So if you have a question and something comes up, you may want to look and see, is there something about that there that might help me figure out what's going on, and is this really going on in an ethical way? Ethical considerations when treating erectile dysfunction. So often we get religious-based objections to providing treatment for erectile dysfunction in persons who have a sex offender history, who have a sexually transmitted disease. We've gotten them for people who live what some providers may feel are less conventional lifestyles, etc. That's one where we have we often have folks come forward with, wait, I don't believe this is okay in my world, and now you're asking me to take care of somebody, and how does that work? So lots of interesting things here for you to look at. And then some additional ethics resources that are available to everybody. If you've wondered what the AMA code says, AMA Virtual Mentor is a great resource for articles. End-of-life palliative care. Ethics in Medicine is probably my favorite overall site for the basics of ethics. And it'll take us there in a second. If you just want to learn outside the VA, it has all kinds of cases and topics and resources. As you can see, it's I always use it a lot with my trainees. Breaking Bad News. And this is from the non-VA perspective, but is still, I think, very valuable and useful place to learn more. Spirituality in Medicine is here, and you obviously would find that of interest. Let me see if it'll let me go back. Yes, it will. The rest of these aren't quite as useful, I think, for you all. So I've now concluded my tour of the National Ethics Center website and all the resources that are available to you as chaplains. And I thought I would finish up because I don't think I have any direct questions. I wish I did have some, and maybe we'll get some later and we can come back and talk about them. But I'll tell you about a couple of cases that that I've participated in where there was an intersection of religion and ethics. One actually with Chaplain Mellon. We had a patient in the intensive care unit who had a woman who had been living with a woman for a very long time, but wasn't his wife, never married her, probably 20 years or so. Our particular state doesn't honor common law marriage, and nor does the federal system. He very much wanted to get married to her, He was in and out of altered mental status, delirium, we call it. And everyone was kind of divided on whether this should happen or this shouldn't. A lot of social workers were upset that he was going to be exploited and she was just doing it to get his money because I believe he was 100% service connection. There was, the ever-present family who comes out of the woodwork and suddenly says that, she's awful and we're good and we should be the ones making decisions. The chaplains were really, really caught in the middle. They wanted to make good, they wanted to help, but they also were concerned because it is marriage is a spiritual state primarily, but also, one that the state authorizes as a legal contract. So it was sort of at an impasse, and we were able to get psychiatry to conduct a decisional capacity assessment. And indeed, the patient was confused about some medical things, but he was very clear and consistent that he loved her and that he wanted to marry her. Had a long interview with his partner, who clearly loved him and was not out to get his money. And they were even able to say, yeah, we should have gotten married or done something about this before. He was very ill and not expected to live very long. The chaplains came and nurses arranged everything and had a little ceremony and were able to get them married at bedside in the ICU and complete the paperwork, and he passed several days later. But there's an example of it turned out well, but it was a difficult ethical dilemma. The chaplain didn't want to marry somebody who he couldn't, authentically and rationally enter into that serious obligation. But we all, our hearts were breaking. Everybody was crying because it was so sad, and we wanted to help them if we could ethically do so. So that is an important area. I will also say another area that is LGBTQ care, and some chaplains have religious beliefs that make that a challenge for them. Others don't and feel like having religious beliefs that that LGBT care is problematic are themselves problematic. So there's lots of tension. And in the VA, the general ethical approach is that we have to serve veterans and take care of them and offer them all our services. But if there are specific conscientious objections based on your faith persuasion, then you would go to your chief and you would try to find another chaplain that doesn't have those same concerns, who could provide that pastoral service, say Warriors to Soulmates, something like that. If it's really an extreme situation and you're the only chaplain and an LGBTQ person needs it, then we would say we have to try to put the veteran first, just as we would as practitioners. And many times it's, there's different healthcare professionals that have objections, either religiously or morally based. So the patient comes first. We're not so much focusing on specific religious or moral beliefs, but can we accommodate the needs of the patient and also respect the professional and personal integrity of the practitioner. So that's a whole nother area. I think you're aware that federal law does not allow us to discuss either abortion or physician-assisted suicide or provide referrals for those. The latter has proved a real challenge in states where physician-assisted suicide is legal, such as California, Oregon. And so often healthcare practitioners may have religious commitments or moral stances that on both sides of that very controversial issue, and chaplains may as well or be asked, to minister to people or to provide support and guidance to staff that are struggling with those. So I think that's another area that's can be quite contentious. The last area that I would really say, and I'm not going to go too much into this, but as you know, we have new spiritual and religious and pastoral directives regarding, religious literature, symbols, signs, etc. And so this is a very this could be a really positive thing in that we're all able to be more aware of our multifarious spiritual traditions. And the danger is, of course, in proselytizing or having a veteran feel compelled or coerced or put upon, which we never want to do. And I think we all, learn that in clinical pastoral education. But I think a number of chaplains have ethical concerns about how those directives will be applied. On the other side, we can also see that a more prominent place for, a whole diversity of spirituality and religion in healthcare can be a very good thing. But it borders on a boundary, and boundary crossings and violations are as important for chaplaincy as they are for mental health care and all of professional health care. And it gets very difficult. I think it's actually harder for chaplains because you're kind of never off. And you are welcoming and open to everyone. So a good rule of thumb is, again, know these policies, know your own guidance as chaplains, and always reach out for consultation and supervision when ethics lives in your stomach, and when you have that uncomfortable feeling that something isn't right, get some help. When in doubt, give a shout. And then last, I know that chaplains sometimes see things happen with healthcare professionals that they think are untoward, are improper, or even unethical. And so I encourage you to contact your ethics resources that we've gone over, and also to educate yourself. Sometimes something may look wrong, and there are things that we don't know about it. And sometimes you may be right, and it really is not okay. We have an aging population that's alienated. Probably the biggest struggle we have is how do we care for and keep safe elders who don't have capacity, don't have families, while also not depriving them of liberty and respecting their autonomy. So you may talk to somebody that seems okay, and they tell you, I want to get out of here. Chaplain, you need to tell him to let me go. And the doctors tell you that he's not able to make that decision, and it's a real challenge that the entire healthcare system is trying to figure out how to most to resolve all those conflicting values in a way that puts veterans first. So those are a number of the issues that I can think about that have come up in my work in 20 years in the VA. And I'm sure you have other questions and concerns. And I'm happy, as I said, it's cynthia.geppert@va.gov, and I'm happy to answer those. I'm also very pleased to work with you on individual projects if you're doing those in your advanced training. There are many end-of-life issues, especially artificial nutrition and hydration. I'm just looking at the different things you've been assigned. Some people have religious objections to the withdrawal or withholding. I can tell you that withdrawal and withholding of artificial nutrition and hydration or of natural hydration and nutrition has been legally and ethically, there's a consensus that a surrogate can make that decision and an informed patient can make that decision. Although certainly it's emotionally wrenching for families and patients. And there are some religious groups that also have conscience clauses about that. And so that's another area where it's ripe for the mediation of an ethically informed, attuned chaplain. So I think I'm done. Matt, is there anything else?
That's great.
Thank you very much for hosting me on Skype, and the best of luck with your advanced program, and thank you for the initiative to take it on.
Awesome. Thank you.